Good morning and welcome to this session on quality standards, especially monitoring and implementation of quality standards in the field of harm reduction. During this presentation, I would like to share with you some ideas about quality standards, what they are, and how they can be implemented in practice. This presentation is based on a European project we just started together with colleagues in different European countries, member states, actually to enhance the degree of implementation of quality standards in the field of drug demand reduction. Well, quality standards, I think most of you have heard about quality standards. But when it comes to implementation, it seems that implementation is still limited. When we look back at the last 20 years, then we see that there has been a promotion of evidence-based practice, evidence-based practices, and also evidence-based guidelines. So interventions that have been studied intensively and for which also efficacy and efficiency of this intervention has been demonstrated. And quality standards are actually a measure or a tool to increase the use and the application of evidence-based practices. Since many years, quality standards and implementation of quality standards is an important part of the EU Drugs Action Plan. That was so in the past action plan, and that's the case in the new Drug Action Plan. I think it's especially thought that these quality standards can bridge the gap between science and practice, because as I said already, evidence-based practice is a very nice principle in theory, but in practice it seems that not always the interventions or methods that are widely evaluated and that have been shown to be very effective are also the most widely applied methods. So we see regarding quality standards that there is different national and international initiatives to promote the use of quality standards. But at the same time, we see also that there is large between and even within country differences and variations in this respect. Also, clear differences can be observed between prevention, treatment, and harm reduction. Especially prevention has done a lot of efforts in recent years to promote quality of prevention, and quality standards have played an important role in that respect. Treatment area is very diverse, and that's also why there is a lot of different phases in this area. And for harm reduction, I think it's somewhere in between treatment and prevention. So also a lot of variety, and also important steps regarding quality assurance that have been taken. Why are quality standards needed? While I think it's mainly to improve and to enhance the quality of care, but there is different stakeholders involved. And so an important objective is to enhance the accountability of services and provide minimal quality guarantees for service users across and within EU countries, so that people will receive the same quality of care, the same quality of harm reduction services, for instance, in Estonia as they do in the Netherlands or Spain. To improve the quality of service delivery is, of course, a very general objective, but we believe that quality standards can contribute to that and to provide more individualized care, personalized care, continuing care, and also more effective and efficient services. But also quality standards may help to increase transparency. Why do some people get care, why others don't? And so if quality standards are there, this can certainly contribute to the quality and the transparency of services, but also it may facilitate feedback and evaluation of the services provided. And finally, yeah, I think it's very important objective of this project and also of quality standards to enable the implementation of quality care in daily practice, and therefore, of course, these quality standards need to be implemented in practice. There's a lot of debate around this topic because I think there is very similar terms that are often confused. First term is standards or quality standards. What is meant by quality standards? They should be regarded as generally accepted principles or sets of rules for the best, most appropriate way to implement an intervention. But these set of principles, they may be very, very difficult to meet by some services. They may be very aspirational. So often a distinction is made between minimum and ideal quality standards. And minimum quality standards are then standards that should be met by all services, while ideal quality standards should not be met by all services, but may not be feasible at this moment for some of these services. Quality standards better can refer to content issues, processes, or more structural aspects. So these are principles regarding accessibility of services, regarding staff composition, regarding also the way service users should be addressed. Typically, standards are evidence-based and provide clear, aspirational statements on how treatment should be provided. So it's really a part of quality assurance. And when quality assurance is defined, then you see that this is a much more broader term. Quality standards are just one part of quality assurance, which is the process of continuous monitoring and striving to improve quality outcomes. It includes the assessment and evaluation of quality of care, design of activities to overcome deficiencies, monitoring to ensure effectiveness of corrective steps, etc. So quality assurance can be regarded the broader process and the broader system, but then also in this quality assurance system, we talk about accreditation, certification, auditing, guidelines, very similar terms, but still they need to be distinguished. And accreditation is the process better by which an institution is delivering services and in which they are also assessed for the quality of these services against predefined criteria and standards. So the accreditation typically is run at certain moments, and certification is a formal attestation. So the process in which a service receives a certificate and attestation for the services they are providing. And auditing is then systematic examination of an activity inside the service. So it's a much smaller unit. So it may refer to internal audits by the organization themselves, or as with accreditation by an external provider. So external audits, we refer them. And guidelines are then very specific instruments that present systematically developed statements for helping practitioners, service providers, service users, and to make informed decisions in specific situations, while the standards refer to a general set of principles. This is really how, for instance, to provide help to people with opiate addiction disorders, or even people for helping them to detoxify or set up substitution. What quality standards are available in the field of harm reduction? Well, there is several better. There is international standards available, and the first minimum quality standards that were provided in this area were the EHRC study quality standards, which have then been reduced and condensed into like 16 quality standards for each drug demand reduction area, so for the field of harm reduction in 2016, but also other international organizations, because this is or these minimum quality standards of 2016 were provided by the European Commission. UNODC also has developed international standards as well for treatment as for prevention, and the latest ones for treatment were published in 2020. But also on national level, we see various efforts. For instance, in Switzerland, where they have developed a really well-developed system of quality assurance, as well as in the Netherlands. In Switzerland, they have these quality standards for almost every type of treatment, also for instance, for drug consumption rooms. The development in the Netherlands was quite different, because they first had like accreditation and accredited addiction treatment organizations, while recently they started changing this and started from the service user perspective, and together with practitioners and service providers, these service users have developed quality standards of care for services, which have been also acknowledged by the health insurance company. So that's a very interesting development in this respect. And of course, there are guidelines for very specific interventions or harm reduction strategies. I think one of the most evident ones is the WHO guidelines on substitution treatment, for instance. But also more recent efforts refer to best practice indicators that have been developed by the EMCDDA for monitoring quality of harm reduction services. And of course, there is inspiring practices from other areas, like the European drug prevention quality standards that have been developed in the prevention area, including a lot of webinars, trainings, toolkits, which should enhance and which have enhanced actually the implementation of quality standards. Good. Well, before we go over to the other presentations, I want to briefly conclude that there is a wide range of quality standards available, but that these standards are not widely applied. And so the main challenge is how to better implement, how to better apply these quality standards in daily practice. And we hope with the FENIQS EU project to contribute to this limited implementation by picking up good, interesting practices from several countries, and to learn from these practices, and that this can be inspirational, this can be aspirational also for other countries. Thank you very much for your interest in this presentation.
Hello, I'm Ganna Dovbakh, and I need to share the situation with the harm reduction quality in Central Eastern Europe and Central Asia countries for the European Harm Reduction Conference. Actually, we are speaking about going back to the roots or forward to the roots to ensure quality of harm reduction. We have challenges with the access to opioid agonist treatment in countries of Eastern Europe, and none of the country, even the program exists in majority of countries, none of the country have more than 50% of coverage, and majority of countries have coverage of OST less than 20%. Speaking about needleless syringe program, we have a big crisis with the access to harm reduction in Russian Federation, where it's almost forbidden and closed, in Romania, in Bulgaria, in Bosnia and Herzegovina, in Hungary, in Albania, and we have challenges with sustainability of harm reduction programs in majority of countries. But why we're speaking now about standards and quality? Because actually, we have not only a lack of funding, but in majority of countries, we have very shortened, optimized so-called package of services. Why it's happening? The basic understanding of harm reduction players is very simple. Clients or beneficiaries not paying for services, and service payer or orderer, which is government or international donors, as it is in big portion of Eastern Europe and Central Asia country. This is different players, clients and service providers. And that's why the question of ensuring quality of services and responding to the needs of people becoming crucial while governments start procuring harm reduction services from service providers. And in this case, we have question, and this question is asked by all associations strategically. We are uniting majority of service providers in the region, and we are defining quality and goals of harm reduction through key elements of harm reduction, key components. So if we see that the goal of harm reduction is reducing legal, health, and social harms and risks from drug use, and the health, we understand psychological, mental health, all infection diseases, including COVID, and access to basic medical health care, then it's much broader than the HCV or HIV testing or referral to the treatment. And that is the key point in our regional discussion of the quality of harm reduction services. We all understand the basic mechanism of ensuring the quality of services, which should include external independent evaluation, internal evaluation of the system in the provider of services. But in the same time, we all understand that we need to use some standards as a tool for quality assessment, which done by provider of services, as well as the clients of services, as well as the those entities, organizations, agencies who are procuring the services. And the key challenge is in this standardization is that international guidelines or standards like I Do It, they are developed in understanding of harm reduction as a service for reducing HIV prevalence and ensuring access to HIV testing and treatment. And they include some components, as we know from WHO guidance and from I Do It, they include components of overdose prevention, they include hepatitis C testing and treatment, they include testing on tuberculosis, but they rarely include services which ensure legal help or paralegal help. Now they include overdose prevention, but they rarely include general access to general health services, because they were developed by us and advocated by us as a part of HIV response, but not as a part of ensuring health for people using drugs. And this is the key methodological challenge. And that's why we are now talking about the quality. We all understand that those who pay for services, they could and should monitor the quality of services. But if aim is set as a HIV prevention, then they formally monitor coverage by harm reduction, but they hardly monitor the quality of life or any other components of the harm reduction, and they don't see the components, they don't pay for the social care, employment, housing, or even overdose prevention, not obviously included in the package which they are paying for. And honestly, state officials on the national or subnational level hardly could have the professional understanding of harm reduction enough to monitor the quality of harm reduction. Thus, we need to build the trust. And in Eastern Europe and Central Asia, that's the most challenge. Trust from the state authorities who are paying money, taxpayers' money for the services. We could use, of course, the quality assurance assessment or community-led monitoring by beneficiary or the association by clients. And last 2 years, we as Eurasian Harm Reduction Association developing these tools to have community-led monitoring of access to services, of quality through the different tools like mystery shopping, like comparison of service with standards, national or international, assessment of satisfaction by clients with services, gender audit of services. We have developed a massive range of tools for community-led monitoring. In this point, the most important part methodologically is the dynamic of power. And that's where we have challenges. Who is ordering, who is paying for community-led monitoring in this case? How to ensure independence and avoiding the conflict of interest in this case, and how to ensure using of this data in advocacy. And that's what we are learning together with the community groups in the region. And we succeeded in several points, like Ukraine, Georgia. Our community-led monitoring bringing this knowledge, and if it is coordinated by regional network, this works much better than in case if the national authority who is paying for services in the same time ordering or paying for community-led monitoring. And that's an important point to ensure quality. And from the provider side. For us as association who unites providers in very challengeable region, we now start working on combining all the systems which our providers, our members have already in place. Majority of them have really good system of training and supervision of employees, even if it's not paid in the service package. They have internal monitoring system. They have feedback systems from the clients, from beneficiaries. They have regular review, and they are rather flexible to respond to the needs of people using drugs. In this case, I'm not sure that the quality standard as a regulation need to be used, but what we need to use is the approaches to ensure qualities by providers. But we have challenges, and these challenges are connected with the fundraising, which we need to do to have the system in place, like learning system, supervision system, training system, and monitoring of quality. And that's the biggest challenge as for now. And how we see ourselves and what we are prioritizing now for Eurasian Harm Reduction Association. We prioritize unity of service providers. We already created expert group on quality of harm reduction in the region, and we are planning to have peer support for members, and we are planning to have service quality benchmarks or criterias based on European service harm reduction criterias, based on I do it as a method guidance, based on the best practices from all over the globe, but also grounded in our practice, what is real to implement. We have really good intention to have supervision, mutual training within the association, mentoring visits on demand by peer expert who want to improve the quality of harm reduction and who want to help other peers, managers of harm reduction, providers of harm reduction in this movement to the quality. And of course, we are ready, and we are already playing this role of advocacy voice to ensure the quality, to fund quality, to make the budget for the quality. And what we could do also as independent regional player is to support community-led monitoring done by the community groups. Actually, that is the key priority directions for us, and that's the most important agenda for association. We really keen to develop the quality of harm reduction and to maintain this. It's not easy way for all of us, but that's the only way to be flexible, to respond to the needs of people, and to build the mutual trust between the local authorities or national authorities who are paying for harm reduction and organizations who are respectful in providing the best quality of services. And we all understand that this need to have a lot of discussion, development, bravery, ambitious, and mutual respect between people who are using drugs, all time new drugs, all time changing the drug scene, all time changing the needs, and providers of the services. And that's actually the most important part in our strategy for the next, I would say, 3 years at least. And we hope that we all will cooperate in this. Thank you.
Good morning, everyone. My name is Rafaela, and I am a research officer at Correlation, the European Harm Reduction Network. And I'm going to present to you our efforts to monitor the quality of services of harm reduction from a civil society perspective. So civil society has a very important role in monitoring harm reduction. Civil society organizations are usually the first contact point for people who use drugs and have an inside knowledge and information that are critical to develop better service and better policy planning. But still, there is few attention to civil society-led monitoring, what it can add, and how civil society organizations can contribute and meaningfully participate. So there are already well-established monitoring activities in Europe to monitor drug trends and the developments of harm reduction services. Here are two good examples: the European harm reduction, the European Monitoring Center of Drug and Drug Addiction since 2007 have a systemic monitoring of drug trends and several other developments in the drug policy in the EU and a few other countries. They still do not systematically reflect the quality of services from a civil society perspective and from a user's perspective, and that's where civil society-led monitoring could potentially add. And the Harm Reduction International conducts a biannual survey since 2008, including practitioners, academics, civil society, advocates, activists, providing an independent analysis of the state of harm reduction. But since it is a global state, it focuses on the global level and has a generic overview per region. So in that sense is where the civil society led monitoring of correlation could potentially add to offer more in-depth knowledge about policy implementation on the ground in Europe. So this is a framework of the monitoring. We are developing this framework since 2018. In 2018, we started with piloting monitoring activities in 5 countries. And nowadays we have 36 focal points in the cities that you can see in the graph. The focal points, the system we have is a community-driven survey. So the themes are decided by members, the questionnaires are designed and revised by expert groups, which is a mix of community members and external experts from universities or health institutes. And we focus on different themes. So we have hepatitis C, overdose prevention, civil society involvement, and new drug trends. Those are the main themes. And in the last 2 years, we also included essential services of harm reduction and COVID-19, how it affected harm reduction field. And also now this year, we will include harm reduction work in prisons. So basically the monitoring focus on policy implementation. So how policies, harm reduction policies happen on the ground. And the national focal points, they are civil society organizations mostly providing services for people who use drugs, and they collect the data via an online survey. The survey focuses on experiences on the ground related to policy implementation, availability of, and access to services. This year, specifically, the data was collected between May and July, and if you want to know more about the methodology we use, you can go to our website and we have publications on that too. But what I wanted to focus now is on a few added values of the civil society led monitoring and some challenges also we have. So one very important added value is to map discrepancies between official policies and policy in practice. So I bring here 2 examples just to illustrate. For instance, we take home naloxone programs. So these are programs where people can have access to naloxone outside the service. And what we see is that there is a mismatch between guidelines and regulations and service delivery or the experiences of people accessing these services. So this is data from last year, from 2020, and from the 36 focal points, 12 reported having take-home naloxone guidelines for take-home naloxone or regulations for take-home naloxone in their cities. But only in 4 of these cases, take-home naloxone was widely accessible. And we mapped then several issues that are related to the implementation of this, which makes it difficult for people to actually access it on the ground. You can see here some, they remain, most projects remain very local based, so they don't expand. In some cases, there is medical prescription needed for people to take naloxone with them, or is only available for those with enrolled in opioid agonist treatment, or there is no access to family and friends of people who use drugs. Another example of mapping discrepancy of policies as they are implemented is the availability of DAAs for the treatment of hepatitis C on people who inject drugs. So DAAs in principle, in the guidelines, they are available in all countries. But in 13 countries, they actually have restrictions in practice. So the most common restrictions are related to active drug use. So it could be that people need to be enrolled in opioid agonist treatment to be able to access the AA, or is only accessible to former users. So people have to be in abstinence, or they need to perform a urine test to prove that. It can be restricted to those currently injecting drugs. They could be using other drugs, but not in other forms, but not injecting. Or it could also be restricted to those with health insurance, which is not the case for many people who use drugs, which are in more vulnerable socioeconomic conditions. Besides mapping discrepancies in policy implementation, civil society organizations-led monitoring can also provide important tools for advocacy based on these results. So in an evaluation we did with our focal points last year, 94% of them said that the results could be useful for their advocacy work in their regional or national places, but they were not very fond of our 100 pages report. They found that a bit too bulky, the way the information was shared for advocacy purposes. So what we did was to transform this 100 pages report, having the report still for researchers and other people doing monitoring also to consult, but have the information also in fact sheets, policy briefs, executive summary. We translated in different languages, but we do notice that we need more than that for people to be able to use this monitoring on the ground. And this is part of our current questions or challenges, how to do that. So some of these challenges that we have. So building a monitoring and evaluation takes time, and takes time to build consistency. So monitoring is not a core business for people who work on the ground. And at the same time, that's the strength of the monitoring and civil society-led monitoring, that also it takes time for people to get used to it and for us to find ways of doing it. Also, there's no dedicated funding for people for focal points at the moment to do this, which makes it difficult in terms of priorities. Representativeness is also an issue. So most of the services, they are local organizations, so they cannot respond for a national context in a reliable way. But at the same time, this detailed experience they have at the local level is very important for the purposes of the monitoring. And so focusing on this expertise, we changed for focal points to represent, rather than a national level, a city level. And we also focal points also try to engage with other people around other local experts, civil society preferred, to represent potential different views that are in their region. And finally, finding the right indicators is a challenge to measure access and quality of services and compare across cities and a long time a different variety of places and realities and contexts. Some lessons that we got from the monitoring so far. So the monitoring points at bottlenecks of policy implementation. It offers a perspective from the front lines. This is data that is essential to local planning and quality of services. It can complement data from other monitoring agencies and is an opportunity for civil society to reformulate indicators and define which data is needed for a better policy implementation and service provision. Finally, some of our current questions. How to monitor other features of quality services. Currently, we monitor access, training of professionals, among others, but we could be more comprehensive in monitoring the quality of services in Europe. How to improve also meaningful involvement of people who use drugs. We had survey also among people who use drugs via the European network of people who use drugs. But we need to improve this partnership and involve more people, service users, to have a more comprehensive monitoring. And finally, how to assure sustainability of the civil society-led monitoring, how to assure that this can continue for the years to come. This was what I wanted to share with you. Here you have our report from 2020. The 2021 report should be available in December this year or early next year, and you can find previous reports on our website in this link. Thank you very much.
Hello, my name is Peter Sarosi, and I represent the Rights Reporter Foundation. It's a small human rights NGO based in Budapest, Hungary. And I am also a member of the Civil Society Forum on Drugs, which is an expert body of the European Commission. Today I will talk about the quality standards for civil society involvement we developed together with other members of the Civil Society Forum. So the CSFD itself, as I said, it's an expert group and it has 45 members selected for a 3-year mandate. It is an ideologically, regionally diverse, multidisciplinary group, and it has 4 thematic working groups, and 1 working group is dedicated to civil society involvement to assess the situation in the EU and also recommend some new innovative ways how to involve civil society in a better way into drug policies. So this year or last year, we started to develop civil society involvement quality standards based on existing quality standards for demand reduction and so treatment and prevention. Why do we need the quality standards for involving civil society? These standards are not only good for decision makers, but they are also good for civil society actors. So they are good for decision makers because these quality standards describe the necessary steps in the planning, implementing and evaluating civil society involvement. They also help decision makers to identify civil society organizations, activists, to create selection criteria for a balanced representation, to create mechanisms to involve civil society organizations. It's also a tool to monitor and evaluate civil society involvement. And it also ensures decision makers that their investment into civil society involvement will be cost efficient. And the quality standards serve a good purpose for civil society as well, because they enable civil society organizations to make their voices heard and be represented. They ensure transparency and accountability of civil society involvement. It provides kind of reference point when civil society organizations are not consulted in a meaningful way, then they can point to this document. And also it is used as a tool to evaluate the government's performance in involving civil society. So what are the important aspects of quality? So how can we define quality when we talk about the involvement of civil society? So when we speak about high quality civil society involvement, we usually mean that it is a mutually relevant and meaningful engagement to both the decision maker and civil society organizations. It is balanced and competence-based representation of civil society. Then it is used, the civil society involvement is used in preparing and evaluating decisions. There is an adequate funding, which is also an important aspect, and the whole procedure is sustainable and formalized. But in reality, what we see is that civil society involvement is rarely fully meaningful, and often it is just a box-ticking exercise for the government. There is no or low funding for this engagement. Governments often cherry-pick NGOs that are favorable to their views, and the representation is not balanced. And also sometimes civil society involvement is only used, to rubber stamp decisions of the government. Often it is ad hoc and informal. So according to our intentions, the document we created, it can be used to bridge these gaps. First of all, what we did, we conducted an assessment and a literature review of the existing recommendations and the documents of civil society involvement. This report can be, it is available on the Civil Society Forum's website. So if you Google Civil Society Forum on drugs, you will find these documents. So this report presents the competing definitions of civil society, the purpose and benefits of civil society involvement, forms and steps of civil society involvement, what are the principles, recommendations from international organizations, what are the facilitators, what are the barriers, so such as the phenomenon which we call the shrinking space of civil society, that NGOs are increasingly repressed and then excluded from decision making. We also give some positive examples for cooperation between governments and civil society, but also some challenging or negative examples. And also we are assessing the risks and opportunities that funding means for civil society. And based on this report, we developed another report, which is the actual quality standards of civil society involvement in drug policies. So in this report, we present to our audience what makes civil society meaningful. It is a kind of practical guide for both decision makers and civil society organizations. And it provides generally accepted principles and a set of rules for the best, most appropriate implementation of civil society involvement. And it is based on the drug prevention quality standards that was developed by European organizations and institutions before. So we use the same cyclic model of civil society involvement, which includes 6 steps of a process of civil society involvement, and it also includes 9 overarching quality criteria. So the 6 steps are, first of all, we need to map and select civil society organizations and representatives. The second step is we have to formulate the mandate for these representatives. Then it is needed to set the agenda. Then the drafting or preparing decisions happens. Then decisions are implemented, and it's also important to involve the civil society organizations in the implementation of these decisions, and also to involve them in the monitoring and evaluation of decisions, because that will serve as the basis of the new cycle. And the overarching criteria are like the 9 criteria are transparency, balance, timeliness, approachability, competence, openness and trustfulness, autonomy, sustainability, and relevance of the whole process. So just to give you a practical sense, what does it mean in practice, and how these quality standards look like. So we organized this document according to the 6 steps, and at each step we try to show how this overarching criteria can be implemented and ensured. So, for example, when we talk about the mapping and selection of civil society organizations, we would like to ensure that this process is balanced, then we mean that, for example, the professionals should be identified from a multidisciplinary background. So not only like from criminal justice, but we need public health and social experts. Then the whole process needs to ensure the involvement of the most affected communities. So that is people who use drugs. Then that we need to ensure gender balance in the civil society involvement procedure. Another example is that when we are talking about the setting of the agenda for civil society involvement, and for example, we would like to ensure that this process is timely. What does it mean in practice? That a clear timeline should be provided for the whole decision-making cycle to the civil society representatives by the government, that civil society organizations need sufficient time to prepare positions. So when a government just asks NGOs to comment on a document in 2 days time frame, that's not sufficient time. And it also means that the civil society organizations have some requirements as well. So for example, they need to respect the deadlines when they need to submit a document. And a third example is when we talk about the drafting and preparing of decisions, and we would like to apply the overarching principle of autonomy into this process. What do we mean? So, for example, we mean that the government should respect the autonomy of civil society organizations who are participating in this process. So all the NGOs should have the right to criticize or disagree without the threat of cutting their funding, that civil society organizations can communicate directly with all decision makers. So for example, when the ministry involves civil society organizations, they should be able to communicate to the members of parliament, for example. And civil society organizations can have their own messages about the decisions when they go to the media. So again, their autonomy should be respected. We also try, to assess these quality standards, like how are they implemented in individual countries and cities of Europe. So we created an online questionnaire in March 2021 to assess what are the perceptions of civil society organizations about existing mechanisms to involve civil society in their countries and in their cities. So we collected responses. We got like 80 valid responses from 26 European countries. Respondents were quite balanced according to their professional backgrounds and the area they work in. So what we found is that according to the respondents, in the majority of countries, European countries, there are existing more or less permanent mechanisms to involve civil society in drug policies. So that's a good news. And we also identified 4 levels of this civil society involvement process, and the less advanced level is when there is only sharing of information between governments and civil society, and the most advanced level is when there is a permanent partnership between the government and civil society. So as you see from the graph below, in almost half of the countries, the mechanism reaches the level of a formal dialogue at least, which is again shows that I think that's a good news. But when we assess the quality of these mechanisms that, you know, it's okay that they exist, but are they box ticking exercises, or do they really work and produce quality exercises? So then the picture is more mixed. So we asked people to rate, you know, their civil society involvement experience according to the 9 overarching criteria we listed before. And what we see is that most of the civil society actors rated that, they said that the approachability of governments is they rated it high, and also they said that there is a frankness, openness between or frank that they can express their opinions frankly at the meetings without fear of repercussions. So that's good news. Bad news is that unfortunately most respondents rated very low the availability of funding for advocacy. So that's a crucial issue, that NGOs do not have funding to do advocacy, and their work is not funded by governments. And they also rated very low the openness from the governments to accept or adopt the recommendations what civil society proposes. So they listen to civil society, but they hear civil society, let's say, but they do not accept what they say. So in reality, it is very difficult for NGOs to make the governments respect or accept what they really propose. So what we would like to do in the future is that from time to time we would like to assess the quality of civil society involvement according to these standards, and I hope that if you visit our website, or if you send me an email, I can send you this document, and you will also find it useful. I think it's crucial that we use these documents to assess civil society involvement, because that's the way how we can improve in the future. Thank you very much for your attention.
Dear colleagues and friends, it's a great pleasure for me to be part of this panel on quality standards, and hopefully I can add some valuable content to discussion and conclusions. I'm going to speak from the perspective of Council conclusions on minimum quality standards in drug demand reduction adopted in September 2015, and the work related to this document done by the Civil Society Forum on drugs in previous years. First of all, I have to acknowledge the contribution of other authors and support by the European Commission regarding my today's presentation, especially the guidelines and recommendations on how to implement minimum quality standards in civil society organizations. Thanks to all mentioned on this slide. In September 2015, the Council of European Union adopted a policy document called Council Conclusions on minimum quality standards in drug demand reduction, based on the wide consensus about the list of proposed quality standards for the areas of drug prevention, treatment and rehabilitation, and harm reduction, known as the EHRC standards. Council conclusions include 16 standards for different areas of work in the field of prevention, risk and harm reduction, and treatment, reintegration, and social rehabilitation. And here you can see a full description and title of this political document. This is a list of 4 risk and harm reduction standards, as the focus of the conference is on this particular topic. So we can clearly see where are the key minimum quality standards highlights in the field of risk and harm reduction. Since then, the European Union Civil Society Forum on Drugs and its working group on minimum quality standards have initiated many discussions on future assessment and implementation of those standards, advocacy activities, and training and education of drug demand reduction workforce. We have also issued a thematic paper even before the Council conclusions were adopted to present our statement on the topic to the Italian presidency of the EU. The standards are defined and described very generally in Council conclusions, so there is a challenge how we can monitor and assess the implementation and their implementation in practice, especially among civil society organizations. The purpose of the Civil Society Forum on Drugs pilot assessment and feasibility study in 2019 was to examine the reality of compliance with minimum quality standards in the field of drug demand reduction. The assessment intends to help EU member states, responsible public institutions, civil society organizations, and other service providers to develop, sustain, and improve interventions in the field of drug demand reduction in compliance with the minimum quality standards adopted by the Council of European Union. At the beginning of 2020, the Civil Society Forum on Drugs produced a guidelines and recommendations for civil society organizations on how to successfully implement minimum quality standards. And the objective of this document, which was developed based on the assessment and feasibility study mentioned before, is to promote the implementation of minimum quality standards in EU member states, especially through advocacy work at the European, national, regional, and local level. You can find the document on the Civil Society Forum on Drugs website in different languages. Drawing on the recommendations related to each specific standard and on the feedback from the assessment and feasibility study, there are a number of conclusions which are important to highlight. These are disinvestment from ineffective and harmful interventions as the first recommendation. Responses to the assessment and feasibility study highlighted that there are still many interventions in the field of drug demand reduction which are not being carried out in line with minimum quality standards. Governments and civil society organizations should be aware of this and consciously seek to disinvest and moving support away from ineffective services and interventions. Correspondingly, they should invest more resources towards implementation of evidence-based and effective interventions, especially in the fields of prevention and risk and harm reduction. The second recommendation is about education and training and continuing professional development. The responses to the assessment and feasibility study pieces also reveal that there is a perceived gap in quality education and training for the drug demand reduction workforce, both in relation to basic training and in respect of continuing professional development. Governments and civil society organizations should investigate the long-term value of investment in this area and look to invest more resources into developing and maintaining quality, formal and non-formal education and training programs for professionals and volunteers in the field of drug demand reduction. And the third recommendation is related to monitoring and evaluation. According to the results of assessment and feasibility study, the evaluation culture is weak in Europe in the field of drug demand reduction. This is not something not very new. There is very little demand by funding authorities and authorities in general for monitoring and evaluation of programs and other interventions, especially concerning outcome evaluation. Without evaluation, it is impossible to say which programs and interventions are effective and has significant impact on the situation in the field of drug demand reduction. So governments and civil society organizations are advised to invest more in monitoring and evaluation, which would significantly improve the quality of interventions and motivation of professionals to continue with quality work. However, those involved in monitoring and evaluation need to make sure of selecting the correct and adequate metrics and evaluation methods in order to avoid large box ticking exercises that may draw time away from the provision of services. Therefore, a balance should be established between the time needed to provide quality services and conducting efficient monitoring and evaluation. And the last and not least important is sustainable funding related to the implementation of standards. According to the results of our assessment and feasibility study, there is almost no sustainable funding for programs and interventions in the field of drug demand reduction. States and funding bodies at all levels are advised to relate funding programs and schemes to the implementation of minimum quality standards, but at the same time, invest significantly more resources to improve the capacity of civil society organizations technical and financial, to comply with those standards. Without sustainable funding, improved knowledge and skills of the workforce, and an improved monitoring and evaluation culture, we cannot expect significant improvements and developments in the field of drug demand reduction. So, thank you very much for your attention.